Howdy, y'all. I'm Dr. Jeff Jarvis, and I want to talk end-of-life care. So we frequently see patients at the end of their lives, and we trained extensively for that scenario, provided that scenario is a 45-year-old male who collapses on a treadmill in VFib. That patient, we know what to do for. We have extensive training, extensive protocols on how to aggressively resuscitate that patient. However, that is a small section of the patients that we actually encounter at the end of their lives. As we get older and we get less and less healthy, we accumulate more medical problems. Our values and desires for what we want at the end of our lives change. They very frequently do not involve the same level of care we would provide for that 45-year-old male. And unfortunately, we don't have a lot of training on how to deal with those situations. Now, we've had training on an out-of-hospital DNR, but that's a really limited form. It really says, do you resuscitate, do you not resuscitate? And it doesn't give us the full picture of what that particular patient's values and wishes are about how they want to spend the last moments of their life. So I would like to talk a little about this concept, and we have an outstanding person with us. We have Dr. Stuart Pickell, who is an internal medicine pediatric physician, a med-peds physician, who is the immediate past president of the Tarrant County Medical Society. That's where we first met. He has been a huge supporter of the EMS system here in Fort Worth. It turns out, though, that's not the reason we wanted to talk. He is also very involved with an organization called Texas Talks. Can you tell us a little about what Texas Talks is?
Texas Talks is a grassroots organization with about 20 to 25 stakeholders representing nurses, doctors, lawyers, doctors in a variety of specialties, hospice organizations, nursing homes, to name a few, that have worked together to try to promote advanced care planning conversations that ultimately lead to the completion of a Polst document, and which better allows us to understand not just whether a patient wants to be resuscitated in the event of asystole or a cardiac arrest, but also levels of care if they are found breathing and with a pulse. So this is something that we believe can really help families as well as help the medical system, because it helps us understand what the patients want, and we're not just giving them interventions that they don't want.
So I like it. The name of the organization really describes what its job is. Texas Talks is about facilitating those talks with patients about what their values and wishes are.
That's exactly right. It's interesting. We originally were called the Texas Most Polst Coalition.
Texas Talks definitely has a better ring to it.
Yeah, we realized we needed a better
you needed some
better
marketing.
name, because it was hard to get that out in an elevator. We had this whole thing about, you have 10 seconds in an elevator, how are you going to explain, you'd be explaining the name
Exactly.
by the time you got off the elevator. Texas Talks was much more descriptive about what we were trying to do.
I'm a guy who pushes a measure called first pass success without hypoxia or hypotension. I get the need for marketing there. Well, you mentioned Polst forms and most forms. Can you tell us what those are?
So a Polst form is a portable medical order set. It's a little bit of a misnomer, because we use the word Polst, and the only reason, which actually stands for Physician Orders for Life-Sustaining Treatment. The only reason we use the term Polst is because that's how the organization started. The National Polst Organization started in the early 90s, and the brand recognition is such that it would be difficult to change that. But the organization has evolved. Our goals with the form have evolved over time. Well, let me say that differently. Our goals for the form are pretty much the same, but the wording and what people think of when they think about physician orders for life-sustaining treatment has changed. Because really what we want is a portable medical order set that outlines what a patient's goals of care are, what their treatment preferences are. And the purpose is to clarify that in the form of a document. So we now refer to it as a portable order set, or portable medical order set, rather than just talking about life-sustaining treatments, because a lot of patients don't want life-sustaining treatments.
And physicians' orders for non-life sustaining, it just doesn't have the same ring to it.
No,
does it?
exactly.
And you're already, if you're own the Heinz brand, you probably don't want to recreate your brand.
Exactly. And a lot of people knew what Polst was, although every state had a different iteration for it. So for instance, in Texas, for years, it's been called MOST, which stood for Medical Orders for Scope of Treatment.
Scope of treatment.
So
Okay.
even the words are different. And
Yeah.
it was La Poste in Louisiana, and Molst in New York, and iPost in Iowa. So it's different in every state.
Well, I'm feeling a little bad because I've been running around saying Molst, and I'm a Texan, and I definitely don't want to adopt practice from New York, so
Yeah, absolutely.
I'm feeling a little guilty. I hope you won't tell anybody.
Oh, well, your secret's safe with me and everybody who's listening.
Oh my. So what is the difference between, you've sort of hinted at this, but I want to be pretty explicit. What we are very familiar with in EMS is an out-of-hospital do not resuscitate form. And that's a very specific state form. All states have them, and we can recognize by law any other state's out-of-hospital DNR form or bracelet or whatever piece of jewelry is approved for that. But tell me how an out-of-hospital DNR is different than the Polst form.
Well, an out-of-hospital DNR basically is very binary. It tells the provider, the first responder, when, and only in this situation, when you encounter a patient who is pulseless, not breathing, do they want to be resuscitated or not? Yes or no, and that's it. It doesn't tell you anything about if in the event that they are breathing and they do have a pulse, how aggressive you want to treat them. Now, the way the Polst forms are set up, the very first section you fill out is that binary decision. If you're pulseless, not breathing, do you want to be resuscitated? And in Texas, because it's a law that you have to have the out-of-hospital DNR. If they check they do not want resuscitation, you must attach the out-of-hospital DNR form to the Polst form. But if they say they don't, but if they are,
They do want resuscitation.
If they do want resuscitation, or if you arrive and they do have a pulse and they are breathing, so you're not to the point you'd be doing CPR anyway.
Right.
The next step is, well, how aggressive do they want to be treated? And that's what section B on the form accomplishes. So there's 3 different levels. There's aggressive care, there's intermediate levels, and then there's comfort care. And patient has the opportunity to spell out and specify exactly how aggressive they want their treatment to be.
So typically when I encounter a patient, either in the field or in the emergency department, and this is a rhetorical question, the answer is obvious, but sometimes it helps to ask the obvious questions. And I want to know, for example, if they want pain medication or antibiotics or a vaccination, or not that we do a lot of vaccinations in the ER, but whatever the intervention is, I just ask the patient if this is something that they want. I don't need to go through all this rigmarole. What's the point of doing these forms?
Well, the patient may not be conscious when they arrive in the ER, but they might still be very much alive.
Yeah.
So in that case, they can't tell you what they want. And if there's no family around, you don't know. One would hope that if there were family, the family would be saying what's on the form and would be consistent with what the patient wants.
We always worry about, like I said, obvious questions. Sometimes I just like to make the obvious thing really obvious. Yeah, they're the expressions of their wishes if they can't speak for themselves. I have dealt with an awful lot of situations with dying patients in the emergency department and in the field where the wishes are not really clear, and there's family there, and there may be a living will or some other handwritten expression of their desires. The thing we always worry about, the scenario we're really afraid of, is that the patient has expressed a desire not to be resuscitated, and the family is insistent that they be resuscitated. Now, having gone through hundreds of these scenarios, I've yet to come up with that event. I know it does happen, but that's the thing we always think about. It's just not the thing that usually happens. Mm-hmm. I think let's do a scenario here, because I think this is not an infrequent scenario. We have a patient who has terminal cancer, let's say. It's lung cancer. They're in a lot of pain, and they're having difficulty breathing. They're hypoxic. Their pulse ox is dropping. They call us because they're very uncomfortable, why they don't have medicines. Maybe they're not on hospice, who knows. And the patient is very much alive, but they're confused. Let's say we have some mets to the brain and they can't really effectively communicate. We're going to the hospital, and our big concern is this person looks like they're about to die. I see a very clear out of hospital do not resuscitate. I know I'm not supposed to resuscitate them, but I also can't just not do CPR in the back of the ambulance, which we can, by the way. That is absolutely something we can do, is not initiate in the back of the truck. Transport anyway, we're still going there, but we just don't do CPR. So the question is, it says do not resuscitate, but what about the other medications that we might be able to use to help them out? Pain medication, for example, or oxygen, or albuterol, let's say.
Well, I mean, that's the whole point of having the different gradations of care that are available. A patient in that situation is most likely to have selected comfort measures. And certainly you could, and that way you know they don't want to be resuscitated. You know they may not even want antibiotics and fluids, but they do, they want to be comfortable. Pain meds, something to relieve the air hunger. I mean, these are the types of things that could be specified on a form, like a Polst form, that could help clarify any ambiguity regarding what they would want.
I think a scenario, I don't necessarily know, I think this is more a question about general end-of-life care than it is about the Polst form. Frequently, this patient who is at the end of their life, death is imminent, we're thinking the next hour to 2 to 3 hours, and they are suffering from air hunger. Frequently, hospice organizations have protocols for giving an opioid and a benzodiazepine. A frequent concern isn't that, I know I don't allow, outside of this context, I don't allow mixing a benzo and an opioid in a non-intubated patient because of the risks of respiratory arrest. Well, if we are giving this person a benzo and an opioid, isn't that the same thing as, and we're not going to intubate, isn't that really the same thing as assisted suicide or euthanasia?
Not if you are treating a condition. I mean, that's the principle of double effect, really, where you're trying to relieve a situation that might, in the end, create an undesirable outcome. It's kind of like you're damned if you do, damned if you don't kind of thing. So, I mean,
turns out this is the type of thing ethicists love to discuss.
Of course they do.
Talk a little bit about the double indication.
The double indication of
like, you are, yes, the treatment, what you're doing is you're treating these symptoms. You're not trying to facilitate. Your intent is not to facilitate.
Right,
death.
and I think intent is important. So I didn't realize we were going to get into this, but we were going to talk about
I didn't know we were going to
ethics and assisted suicide and all of that. But I think that the main difference is intent.
Yeah.
So you hear a lot about physician-assisted suicide or physician aid in dying or whatever your preferred reference point is. The difference is that with physician-assisted suicide, the intent is to end their suffering by ending the patient, and ending their lives. Whereas in this case, your intent is to relieve the suffering, knowing that by relieving the suffering, it may promote the end of their life.
Emphasis there on may. That's not the intent.
It may not.
Yeah,
because it's not the intent.
Right. And I was particularly worried about this, and I'm a weird person. I actually, from time to time, read books about ethics.
No.
Sorry, please don't hold that against me, y'all. And I actually saw that there are entire books written about this concept. And this is pretty much a well-known concept. And it is absolutely okay in this context to treat the air hunger. And if death happens 5 minutes sooner than it might have without it, that is an unintended consequence, even if you know that it may not be that unlikely.
Of doing the right thing for the patient, which is to relieve their suffering and keep them comfortable.
Yeah.
And this was certainly something I learned in ethics when I was at Southwestern. The County Medical Society, I chair the ethics consortium there, and we wrote a paper on this. When it was supposed to be a relatively brief position paper that turned into 60 pages. We had a lot to say about it.
Apparently.
So, and really, intent is important.
So we have talked about this as though the patient has a Polst form. Not all patients have a Polst form. I have a living will that's part of my estate planning, but I would like to think that I'm still going to be around in a few years. is this something that would be appropriate for me, or is it a different population you're looking at?
It's absolutely a different population. So when we're talking, I think that's a misunderstanding about advanced care planning documents. And when I talk with, I teach ethics at the School of Medicine at TCU, and one of the things I tell medical students is that advanced care planning is important for them too. Of course, they're 25 and invincible, right? They're never
Right.
going to die, and you can tell they think that because I've seen them ski, right? So, but everybody should have a surrogate decision maker, somebody who is designated to make decisions for them on their behalf if they, while they're skiing, ran into a tree and were unconscious.
Right. Without a helmet.
Without a helmet.
After
right.
drinking.
After drinking. I mean, you could.
Don't do that.
We're not recommending it.
No.
But everybody should have a surrogate decision maker. You have a living will, I have a living will. We did estate planning or whatever. We get a lawyer to draft it up, or you can actually do it without a lawyer. And so living wills are important because they at least help to identify what your preferences are, but they don't go into effect until you can no longer speak for yourself. And that's one difference between those types of documents and a Polst document. A Polst document is really intended for patients who are within, if a physician, and I can, as a primary care doctor, I've done this before. I've had patients where I've thought, I would not be surprised if they were to die in the next year. And if that's the case, then they would be a candidate for a Polst document. So these are usually patients who have serious progressive illnesses, often from some sort of chronic condition that's been chronic for years, but last year they went to the hospital once, and this year they've been to the hospital 4 times, and it's getting worse, and there's not anything that's going to make this better. Those are the kinds of patients that would qualify for a Polst document. Advanced frailty would be another one. I mean, because anybody in their 90s, could die at any time, even if there's not much else going on with them.
Actuarial tables would say their odds are not good.
Exactly, which is why we don't do colonoscopies on 90-year-olds, because their chances of living to be 100. Exactly.
Right.
Not routine colonoscopies anyway. So, so these are the types of patients that ought to have them. Now, I've had some patients through organizations I've worked with. I had one that I recommended for this man who had serious chronic illnesses. He was in his mid to late 80s. And his wife, who was a very robust and healthy 78-year-old, liked the whole process so much, she insisted that she also go through it. And we went ahead and did it. I mean, because she wanted to. But she really wasn't the kind of person that ought to be doing this. Yeah. But it's okay if she did.
But there's no harm, because if you can speak for yourself, your wishes, what you're saying, supersede the document.
Exactly.
Right? Yeah.
Exactly. And the other thing is that it goes into effect immediately. It is a medical order, and so it's actionable by people who aren't physicians. Now, we run into situations sometimes with lawyers for hospital systems, for instance, arguing that it's not a statutory document and therefore not a legal document, which it's not a statutory document, but it can still be.
It is not expressly defined in, I believe it's 166.
It's in 166.
Where it talks about these things.
Exactly, in the Texas Code, which is where the
out-of-hospital
DNR comes from that. And that's what they're referring to. And in some ways it's good that it's not, because once you get the legislature drafting things like Polst forms, weird things can happen. But I
don't know. I've heard everything they do is perfect. Is that not the case?
I think I don't know.
You
might want to broaden
smoking?
the sources you're listening to.
Sorry, Leela, don't drug test me.
So, where were we?
Sorry, Leela's our HR person. We were talking about it not being in the statute, and
okay. So their argument is that these orders were not. Would a doctor in the ER, for instance, in their hospital system?
That's freedom.
Okay, is that why did you build this under the flight approach path for Carswell?
Exactly. We now just interrupt the conversation, go, God bless America, and freedom as more planes fly over. You should see the F-35s when they're in vertical takeoff mode or landing mode. Yeah, they're jets like directly on the building. It's a bit loud.
I bet.
Yeah, usually happens when we're recording.
Of course, that's time. They must know your schedule.
That's exactly right.
Well,
let's talk.
I want to finish that thought.
Yeah,
okay, so the lawyers are concerned that the medical order was written by somebody they don't know. Because usually they are certified by primary care physicians, physicians who know the patient and would know that that's what the patient would want as well, because they've talked with the patient about this. What they don't understand is that it's a medical order that's actionable by first responders, but once the patient gets to the hospital, if that's where the appropriate next step is for them to be, those orders then become information for the physicians that are taking them at the hospital, who will then write their own orders, hopefully based on what the patient wants as expressed
Right.
in the Polst document.
Yeah, well, we do have I think that we have an ethical, I would argue also a moral responsibility to abide by the patient's wishes.
Exactly.
And when they can't talk to us, this is the surrogate marker for their wishes. Let's talk about the situation that 166, that statute, unfortunately, specifically excludes EMS personnel, where there's a except for. And it says, you people are different, you have your own section. And the section is referring to the out-of-hospital DNR, and what it is saying is that the out-of-hospital DNR is for us, all these other forms are not for us. Which gets us into a situation, because I think we have this ethical obligation to follow the wishes of the patient, but we're being told we can't follow those wishes. There are a couple of things that we need to understand about this. Number one, another section of that law says this is a penalty-free decision. You don't have to be right, you just have to be doing what you think the patient has expressed. So if the form is not completely filled out exactly right, and you look at it and say the patient doesn't want resuscitation and you don't resuscitate, there's no penalty for that. There is specific protection there. The other issue is that does not apply to me, Dr. Cornelius, or Dr. Miller. If you encounter a situation, the Polst form wouldn't really work here because there's an out-of-hospital DNR that's part of it. But for whatever the situation is, if you encounter some expression of the patient's desires, and that includes a family member saying this is not what he would want, then we have the ability as physicians to alter care based on those wishes. So call us immediately, and we can essentially get out of 166. So we're okay there. Yeah. So sadly, we are both old enough to have experienced several presidential campaigns. There was one a while back where the concept of death panels came up.
Of course there are death panels in there.
And from what I could gather from the messaging, they were bad. We didn't want them.
But the important thing to remember is that's just one aspect of this atrocious, unaffordable, cumbersome, burdensome, evil.
Isn't, just in terms of clearly provocative questions, isn't this Polst form just a manifestation of death panels? Aren't we forcing my grandmother to say what care she wants or doesn't want?
The Polst form is entirely voluntary, so nobody has to fill one out. We recommend that people fill it out because it's an excellent tool for a couple reasons. One, we recommend that these forms be completed with the help of a facilitator who's trained to help you complete the forms. So they know kind of what questions to ask to help you understand how sick, what your condition is, and if you don't really understand it, what questions to ask your physician next time you see them so that you can get that information. But it's entirely voluntary. Nobody's being forced into doing anything. The whole thing about death panels was, it was a poor choice of words.
Yeah.
Because I don't think that's what she intended, but nevertheless, that's how it was interpreted.
Exactly.
And there's always the concern that people are going to be coerced into completing these documents, and that's one of the reasons why, if you Google this, you'll find that a number of folks in the Catholic Church are opposed to Polst forms. I think that there's a serious misunderstanding on the part of that community on what they represent, and a lot of the writing about it is 10 or 12 years old too. So the Polst has evolved quite a bit since then, and in some very Catholic states like Louisiana, they've actually endorsed it. I don't know if officially endorsed it, but they're okay with it. It's further along as far as its saturation or penetration in the state than it is in Texas. Texas has an unfortunate distinction, well, good and bad, of having 5 huge metropolitan areas. And well, I guess, 4 areas in 5 cities.
Right.
That
We
make
hate
it
to include
difficult.
Dallas with us, but somehow everybody else does.
I know. You got to, well, it is what it is. But when you have that many large metropolitan areas, it's really hard to get penetration. It's a lot
Yeah.
easier in a place like in Louisiana, where you've got New Orleans, Baton Rouge, and that's kind of
Right.
it.
Roughly the population of, say, the Metroplex.
Exactly.
Yeah.
Exactly. So, not to put too fine a point on it, but what I'm trying to say here is that I think the Catholic Church is very well-meaning in their concern and caution
Yeah.
about patients being coerced into signing these forms, or them being signed without
Right.
the patient even knowing about it, or somebody signing it on their behalf. Again, what we're advocating is that a patient have a conversation with a trained facilitator to elicit what their goals of care are, what their treatment
Yeah.
preferences are, so that it can be put into an order set that is actionable when it's needed, rather than trying to scramble around and figuring out what was on a living will
Right.
when they can no longer communicate for themselves
Yeah.
what they want.
I think we frequently, all of us likely, have encountered a situation where someone has just gone into cardiac arrest. There is no documentation of what their wishes are. We recognize that at best, resuscitation from cardiac arrest can return you to your pre-morbid condition. In other words, the state you were in before. In other words, CPR and defibrillation don't fix cancer. Sadly, that would be an easy fix for cancer. So we need to understand what the patient's will was, and that's really what we're trying to do, is just facilitate that conversation.
Exactly. And one more thing about the voluntariness of it. The forms are meant to be dynamic in the sense that, I mean, you identify what you want, but that's what you want at this particular point. As you mentioned, let's say that you had another event. You went back to the hospital with another CHF exacerbation or COPD exacerbation, and this time you actually were on a ventilator because you said on the Polst form that you wanted to be on a ventilator. And now you think, I'm not sure I want to be on a ventilator anymore.
Yeah.
I don't want to do that again. We recommend that people revise their Polst forms.
Very good.
And it should be revised every year or every time they get admitted to a hospital. Because at that point, the orders are all changed anyway when they get admitted to the hospital.
Fair point. Yeah. So we've talked a lot about the specific Polst form, but I've also heard about most forms or most forms. What's the difference?
Well, as we mentioned, the National Polst Organization basically has a chapter in every state, and every state might call their form something different. Now, the forms are supposed to be based on a recommended format from the national organization, and pretty much, I think all of them pretty much are consistent more or less with the general idea that the beginning, section A is the out-of-hospital DNR, and or CPR question, and then question
Right.
B is about, section B is about levels of care and that sort of thing. Most was the original name for the Polst form in Texas, and it was started by Dr. Fine at Baylor. And they've been very successful at having these conversations and getting the form in distribution. The Polst form is very similar to the MOST form. In fact, it was patterned after the MOST form. Our organization, Texas Talks, became the official chapter for the National Polst Organization, and so we have followed very closely with the National Polst guidelines, including their efforts to try to standardize what the forms look like in different states. Huge problem in places like New York City, where a person could be in New Jersey, New York, or Connecticut within 10, 15 minutes, and you might have 3 different forms that you're looking at. And so we want them to look as close as possible to each other. And you'll find that in Texas, there's a lot of MOST forms, not as many Polst forms. They look very much the same. The main difference is that the MOST form, which is a Baylor form, does not have a patient signature. Our organization, we looked at the national standards, consulted with the Texas Medical Association, and our other stakeholders believe that we really ought to have a patient signature, and that it ought to be required, because it is a shared decision-making tool.
Yeah.
The patients are really the experts here. When you're writing a medical order, usually you're not going to ask the patient, well, which antibiotic do you want to be on?
Right, exactly.
But in this case, the patient is the expert. And so we want the patient signature to be on the form. And the whole process is supposed to be set up so that a facilitator has the conversation with the patient, and hopefully with their surrogate decision maker, so that they're part of that conversation and hear what the patient wants. And then that form will go to the physician, who will then certify it. So it should have both signatures on it, the Polst form should. But if you see a Most form, I mean, it's an equally valid form. It still has the physician signature, which is, you know, the part that makes it an actionable medical order.
Yeah.
But they're otherwise very similar.
Very good. And I think from our perspective, because of the way the chapter is written, you cannot by yourself follow either one of those around do not resuscitate in the absence of an actual out-of-hospital DNR. We, of course, can. So again, call us and we will clarify them. But they are clearly both representations of what the patient's desires are. So is there, you know, I think we've covered a lot of ground here. We've talked about the importance of following patients' wishes. As Texans, we like to think we are big believers in freedom and personal autonomy and our ability to self-determine our own fate. And the challenge is that when we can no longer speak for ourselves, we want someone to speak for us. And if there's no one there, we want a document like this to be able to express our wishes. So I really thank you for coming in. Before we leave, though, I want to make sure, is there anything else about Polst forms that you want to discuss?
I think we've covered a lot of territory. I think the main thing is to understand that it is an excellent tool for the patient being able to identify what their preferences are, what their goals of care are, and able to break it down into aggressive, intermediate, and comfort measures only. Comfort doesn't mean do nothing. I mean, comfort, you're still doing something. It usually means they don't want to go to the hospital, but there might be some instances where you have to in order to keep them comfortable. So, but if there's other options available, obviously you would want to leverage those or bring those in if they're on hospice and you can get them there, for instance. We obviously believe that this is a very important tool. We really do value the contribution that MedStar and the emergency medical services have made. When we started this initiative with North Texas Specialty Physicians back in 2012, which served as kind of the foundation for what became Texas Talks, MedStar was a very important part of our board, and we've had MedStar representatives on our board quite a bit. I don't know if we do right now.
Well, Dr. Bickel, thank you so much for coming and talking to us. I think this is really helpful, and I think it can really help us do a better job of meeting our patients where they are and accomplishing what they want to do for the end of their life. Thank you so much.
Thank you, Dr. Jarvis. We appreciate the opportunity to share something about Polst.